Dear student, I am Dr. Prakash Mungli, Professor of Biochemistry. So in this lecture of plasma protein series, I will be going over globulins. Especially, I will go over chemistry, functions and clinical applications of different types of globulins. Globulins, upon electrophoresis, they separate into 4 distinct bands. We have like alpha 1 globulins, alpha 2 globulins, beta globulins and gamma globulins. And gamma globulins, especially the IgG type of gamma globulin, constitute the second most abundant component of serum proteins after albumin. Immunoglobulins, we have IgG, IgA, IgM and IgEs. And beta globulin series, we have hemopexin, transferrin, plasminogen and prothrombin and even LDL, that is low density lipoprotein. Coming to alpha 2 globulins. Alpha 2 globulins, we have alpha 2 macroglobulin, haptoglobin and ceruloplasmin. In alpha 1 globulin category, we have thyroxine binding globulin, steroid binding proteins, transcortin, 𝗠𝐭𝐲𝐫𝐞 and alpha 1 antitrypsin. When it comes to site of synthesis, alpha and beta globulins are synthesized in the liver, whereas gamma globulins are synthesized by plasma cells and B cells of lymphoid tissue in the reticuloendothelial system. Coming to alpha 1 antitrypsin. Alpha 1 antitrypsin, which belongs to alpha globulin, it is synthesized predominantly in the liver and it is the principal serine protease inhibitors present in the human plasma. So, it is an inhibitor of number of proteolytic enzymes and more particularly the elastase that is released by neutrophils. So, alpha 1 antitrypsin deficiency has been implicated in emphysema and liver diseases. And the most common phenotype of alpha 1 antitrypsin is MM allele, that is PIM allele here, and that is the one which is associated with normal alpha 1 antitrypsin activity. Now other possible alleles are PIS, PIZ, PIF and PI null alleles. Now the condition that increases serum alpha 1 antitrypsin, that can be in acute, subacute or chronic inflammation, especially because alpha 1 antitrypsin is also considered as one of the acute phase reactant that can be also raised like during trauma, burns, infarction, where there is a decreased circulation of blood to a particular tissue, or it can be increased in malignancy and some liver diseases. And chronic hepatocellular diseases or biliary tract obstructions, in that condition either alpha 1 antitrypsin may be normal or it can be increased. And note that the conditions that decrease serum alpha 1 antitrypsin can be protein losing enteropathies, protein losing disorders like nephrotic syndrome or diffuse hypoproteinemias, and juvenile cirrhosis of liver where decrease in the synthesis is going on, alpha 1 antitrypsin synthesis going on in the liver, and also existing alpha 1 antitrypsin can also be inactivated, especially in smokers. A cigarette smoke may lead to oxidation of one of the critical methionine residue in an alpha 1 antitrypsin protein, leading to decreased functioning of alpha 1 antitrypsin rather than decrease in the concentration of alpha 1 antitrypsin molecule there. Now, there can be a genetic deficiency that can lead to decrease in alpha 1 antitrypsin enzyme and alpha 1 antitrypsin activity. So, alpha 1 antitrypsin deficiency, which is genetically mediated, is following autosomal recessive inheritance pattern. So, homozygous phenotype, that is ZZ homologous phenotype related to PIZ allele, this type of people suffer from more severe deficiency of alpha 1 antitrypsin compared to any other phenotype. Normal phenotype is we have seen already in the previous. So the phenotype of ZZ1, that will lead to severe deficiency of alpha-1 antitrypsin. So deficient people, they will suffer from emphysema and also cirrhosis of the liver. About 5% of all cases of emphysema are implicated because of impaired alpha-1 antitrypsin activity. So what is the biochemical mechanism of alpha-1 antitrypsin deficiency? So first let's look at normal activity of alpha-1 antitrypsin and see what happens if there is a deficiency. Normally what alpha-1 antitrypsin does is, as it is shown here, it is going to go and bind to active elastase enzyme. Note that elastase is going to degrade elastin. So when alpha-1 antitrypsin binds with elastase enzyme, it is going to neutralize that elastase, leading to proteolysis of elastase, and thereby elastase do not have its activity. That means it is no longer damaging the elastin present in the lung, so the tissue damage is prevented. If there is an alpha-1 antitrypsin enzyme is deficient or absent, so what will happen? Elastase will be active and it is continued to break down elastin in the lung, and that leads to tissue damage. That's a simple biochemical mechanism there. Now, alpha-1 antitrypsin deficiency has been related with smoking, that leads to severe emphysema in people who are already deficient in alpha-1 antitrypsin. So, what happens in smoking? So, the cigarette smoke, it is going to oxidize a critical methionine residue that is present in the active site of alpha-1 antitrypsin, that is the 358th amino acid residue in alpha-1 antitrypsin is the methionine residue, and this methionine is involved in binding of elastase and then neutralizing that elastase, breaking it down. So that particular function of methionine is there in alpha-1 antitrypsin. So what happens with the cigarette smoke is, the smoking, the free radicals that are present in the cigarette smoke, it's going to oxidize a methionine residue present in alpha-1 antitrypsin into sulfoxide form, and that inactivates alpha-1 antitrypsin enzyme's function. Thereby it decreases the affinity of elastase towards the alpha-1 antitrypsin, and that happens by 2000 times. Thereby elastase do not bind to the active site of alpha-1 antitrypsin, and that means elastase will have a function. Means elastase is overactive and it's going to degrade the elastic tissue in the lung, giving rise to emphysema. Now, active elastase that causes proteolysis of lung, leading to tissue damage, thereby accelerating development of emphysema. Patients also will develop juvenile hepatic cirrhosis has been correlated with alpha-1 antitrypsin deficiency, and that's because the abnormal form of alpha-1 antitrypsin will accumulate in the endoplasmic reticulum of the liver. It is not being secreted, so continuous accumulation of aggregates of alpha-1 antitrypsin in the endoplasmic reticulum of liver will lead to fibrosis of the liver, and that eventually lead to hepatic cirrhosis. So PIZ, that is ZZ phenotype, accumulates and aggregate in the hepatocyte. It leads to cirrhosis, as I explained earlier. Now, alpha-1 antitrypsin has been used as a tumor marker, especially for germ cell tumors of testis and ovary. And also note that alpha-1 antitrypsin is one of the most important inhibitors of fibrinolysis. Coming to ceruloplasmin. Ceruloplasmin is a copper binding alpha-2 globulin, and also it is a copper transporter protein. So it stores the copper and also it transports the copper from one organ to another organ. So especially in the blood. So ceruloplasmin, it is synthesized in the liver and it has 8 copper binding sites. So 8 atoms of copper can bind to one molecule of ceruloplasmin. And also ceruloplasmin has got an enzymatic activity, that is copper oxidase enzyme activity, histaminase enzyme activity, and also it has got ferrous oxidase enzyme activity. So in fact, there are 3 enzyme activities are there in ceruloplasmin that you need to remember. One is copper oxidase, second is histaminase, and third is ferrous oxidase activity. So 90% or more of total serum copper, it is stored in ceruloplasmin. So it's an important storage form of copper. Conditions that increases ceruloplasmin, it is found in the pregnancy, inflammatory process, malignancies, oral estrogen therapy, and contraceptive pills will all increase ceruloplasmin levels in the blood. Alright, now let's move on to see conditions that decrease ceruloplasmin. So it is seen in two diseases, Wilson's disease and Menkes disease. So because of mutation in gene that is coding for ATP7B, that's for Wilson's disease, ATP7B gene, which is coding for a specific transporter to transport copper out of the organ like liver. And Menkes disease is because of mutation in ATP7A gene, which is coding for P-type ATPase in the intestine. So Wilson's disease is liver and other organs, including the eyes, whereas Menkes disease is the intestine. So that means copper is accumulated in the intestine. So excess copper will be there in the intestine and excess copper will be there in the liver and other organ in this condition. So that means low copper, decreased copper in the plasma and excess copper in the organs. That's what you are going to see in Wilson's disease and Menkes disease. So this is what is the condition that causes decrease in ceruloplasmin. Coming to haptoglobin. Haptoglobin is alpha-2 migrating glycoprotein. It is synthesized primarily in the liver, and the function of haptoglobin is it is going to bind with hemoglobin in the blood vessel. It is the intravascular hemoglobin scavenging protein. So thereby it's going to prevent loss of hemoglobin from the circulation. So by preventing loss of hemoglobin, it is preventing loss of iron from our body. That's the important function of haptoglobin, because hemoglobin haptoglobin complex, it's a high molecular weight complex. It is not filtered by the glomerulus, so it will be taken up by the liver, and liver is going to use the iron especially present in the hemoglobin molecule and use it for hemoglobin synthesis or heme containing protein synthesis. So that's what is the use of haptoglobin. So here in the flow chart it shows, so hemoglobin molecular weight is 65,000. So it can be filtered, renal glomeruli excrete it, so it can be getting out of our body. So that means loss of hemoglobin means loss of iron from the body. Now what haptoglobin does? So hemoglobin 65,000 molecular weight, haptoglobin 90,000 molecular weight. So the hemoglobin haptoglobin complex is 155,000 is the molecular weight. So kidney glomeruli, it cannot secrete it out, cannot be excreted. So we are saving that iron. So iron is saved and reutilized. That's how the haptoglobin functions. Coming to transferrin. Transferrin is a non-heme iron containing beta-globulin. It's a glycoprotein which is also sometimes referred as siderophilin because it contains iron. Always remember the term sidero means it is iron. It refers to iron. You know sideroblastic anemia. So siderophilin, transferrin. So it is synthesized principally and largely in the liver. Apotransferrin can bind with 2 atoms of iron to make a transferrin. That means each transferrin will have 2 iron atoms whenever it is in saturated form. Okay, so it has a capacity to bind 3.4 milligrams of ferric iron per liter of blood. So 1.4 milligrams of iron per gram of transferrin. So that's what is the capacity there. Now the transferrin, it is about 33% saturated with iron and it transports iron from one organ to another organ. Unsaturated transferrin has a bacteriostatic function also, remember that. So transferrin is not only iron transport protein, transferrin when it is not saturated with the iron, it also has that bacteriostatic action. Now, the condition that increases transferrin is iron deficiency anemia, where iron is necessary, so transferrin synthesis is increased just to make sure that iron is transferred to one organ to another organ, and also in last months of pregnancy, transferrin levels can be increased. Now, the conditions that will decrease transferrin includes protein calorie malnutrition because of lack of protein intake, cirrhosis of liver because transferrin is synthesized in the liver, so any issues with the liver will lead to decrease in transferrin. Nephrotic syndrome, loss of transferrin in the urine. In nephrotic syndrome, most of the proteins are lost in the urine. Or acute illness such as trauma, myocardial infarction, malignancies, and other muscle wasting diseases, where there will be decrease in transferrin levels from the blood. Coming to beta-2 microglobulins. Beta-2 microglobulin levels are elevated in the renal diseases, inflammatory diseases, and also in malignant tumors. And beta-2 microglobulin is used as a tumor marker, and beta-2 microglobulin is useful as assessing a renal damage caused by antibiotics, and beta-2 microglobulins is increased in hepatic diseases. So this is something related with beta-2 microglobulin. Coming to urinary beta-2 microglobulins. So urinary beta-2 microglobulin levels will be elevated in Wilson's disease, and where there is a hepatolenticular degeneration process, and renal diseases like chronic nephritis, chronic cadmium poisoning, Fanconi syndrome, all of them will lead to elevated levels of urinary beta-2 microglobulins. Whereas serum beta-2 microglobulin levels are elevated in chronic nephritis, myelomatosis, systemic lupus erythematosus, malignant tumors, abnormal pregnancies, chronic rheumatism, and Behçet's syndrome. In all these conditions, there will be elevation of beta-2 microglobulins in the serum. Coming to gamma globulins. Body's immune system is maintained by B cell lymphocytes, T lymphocytes, and the innate immune mechanism. Now, the B lymphocytes are referred as B cells, T lymphocytes, T cells. Now, the B lymphocytes are from bone marrow cells, while T lymphocytes originate from the thymus. That's how the B and T will come from. So, B for bone marrow and T for thymus derived cells. The B cells synthesize immunoglobulins, which are giving humoral immunity to our body. So, humoral antibodies are humoral immunity that is done by immunoglobulins, which are coming from B cells. While T cells are involved in cell-mediated immunological mechanism, so both and T cells respond in an adaptive manner, developing a targeted response for each invader that are encountered in our body. Now, the innate immune system is done by specific cells that will also fight against invaders, like we have phagocytes, neutrophils, natural killer cells, monocytes, macrophages. All these cells, they defend our body against infection in a non-specific manner. So, these are the three systems that will fight against invaders in our body. That is T cells, B cells, and innate immune system. T cells will give cell-mediated immune system, B cells will give humoral immune system, and innate immune system is through monocytes, macrophages, phagocytes, all this kind of cells, natural killer cells. Now, coming to more on gamma globulins. So, immunoglobulins are oligomeric proteins having antibody activity. Human immunoglobulins can be grouped into 5 classes, that is IgA, IgD, IgE, IgG, and IgM. That is immunoglobulin A, D, E, G, and M. Coming to structure of immunoglobulin G. This is to understand what is the general arrangement of the chains in the immunoglobulin molecules. So, as you see here, IgG has got a H chain and L chain. So, there are 2 chains here. One is of H type, other is of L type. So H for heavy chain and L for light chain. So there are 2 heavy chains and 2 light chains. Light chains are only present in FAB region. So the thing that you are seeing here, this is the overall arrangement of immunoglobulin chains with the H and L chain, just for a general understanding of immunoglobulins. So 2 identical light chains and 2 identical heavy chains are linked together by a network of disulfide bonds, as you see here. So there are disulfide bonds that are linking heavy and light chains in immunoglobulins. And L and H chains are glycoproteins which are synthesized separately by B cells that are plasma cells. And IgG as a tetramer, that is 2 light chains and 2 heavy chains, whereas IgA as a dimer and IgM in fact will have a pentamer. That means it will have 5 chains. If the heavy chain, that is H chain, is of alpha, then the immunoglobulin is referred as IgA, A for alpha. If the heavy chain is delta, then the immunoglobulin is referred as IgD, D for delta. If it is epsilon, it is IgE. If it is gamma, it is IgG. And if it is micro, it is IgM for micro. Now, a given immunoglobulin molecule always contains 2 kappa and 2 lambda light chains, and there is never mixture of kappa and lambda. Now, let's understand different properties and functions and characteristics of each type of immunoglobulins with the help of this table here. So, we have IgG, IgA, IgM, IgD and IgE, all 5 types of immunoglobulin. As you see, a percentage of total immunoglobulin in serums, IgG is the major immunoglobulins out of all the immunoglobulins. So, serum concentration of IgG in terms of milligram per 100 ml of blood is 1000 milligram per 100 ml of blood. And the least one is IgE. The most abundant is IgM and the least abundant is IgE. Remember that. Sedimentation coefficient will indicate the size of the immunoglobulin. If you go by that, so the sedimentation coefficient, you see here, it is IgM. As you see, the molecular weight is 900 times 1000. That is 900 kilodalton there. And sedimentation coefficient is 19S for IgM. Now, the structure, when it comes to structure, IgM has a pentamer, that is something special, whereas others are usually the monomers. Coming to H chain, that is the heavy chain. So, based on the heavy chain, as we have already seen, these immunoglobulins are named. So, immunoglobulin IgG is having a gamma chain, IgA has got alpha heavy chain, IgM as a micro heavy chain, IgD as a delta heavy chain and IgE as a epsilon heavy chain. Coming to complement fixation ability, only 2 immunoglobulins have got complement fixation ability, and that is IgG and IgM. And the transplacental passage or the transfer happens only with IgG. Mediation of allergic response is done by IgE, and the immunoglobulin that is found in the secretion is IgM, and the immunoglobulin that has got an opsonization mechanism is IgG, and antigen receptor on B cells are found in IgM. Polymeric form contains a chain is IgA and IgM. So, these are some of the characteristics there. Coming to major functions of immunoglobulins. IgG, it's a main antibody in response to secondary, okay, let's retake this. IgG is main antibody in secondary response. It causes opsonization of bacteria, making them easier for phagocytosis process. And it fixes complement which enhances bacterial killing, bacterial toxin and viruses, and it also crosses placenta. IgA, it's a secretory immunoglobulin which prevents attachment of bacteria and viruses to mucous membrane, and IgA do not fix complement. Coming to IgM, IgM is produced as a primary response to antigen, while IgG is produced as a secondary response to antigen that we have seen already. IgM fixes the complement, it does not cross the placenta, and antigen receptor on the cell surface of B cells are found with IgM. Coming to IgD. IgD found on surfaces of B cells where it acts as a receptor for antigen. IgE, it mediates immediate hypersensitivity by causing release of mediators from the mast cells and basophils upon exposure to antigen or the allergen. And also IgE defends against worm infection by causing release of enzymes from eosinophils. That's why there will be rise in eosinophils, sedimentation rate and all that. Yes, sir. And does not fix complement, main host defense against helminthic infections. So that's what is the function of IgE. Coming to acute phase proteins or reactants. So these proteins, they will increase during acute inflammatory states or secondary to certain types of tissue damage. So acute phase proteins includes C-reactive proteins, haptoglobin, alpha-1 antitrypsin, alpha-1 acid glycoprotein, which is referred as 𝗠𝐨𝐫𝐞, and fibrinogen. All they are acute phase proteins. Interleukin-1 is the principal stimulator of the synthesis of majority of these acute phase proteins by the liver cells, and interleukin-6 also plays a role along with interleukin-1 in this process. Coming to Bence-Jones proteins. Now the Bence-Jones proteins, these are seen in multiple myeloma, which is a single plasma cell clone disorder. Patients in multiple myeloma show accumulation of paraproteins, which are monoclonal immunoglobulins, and they may be of IgG, IgA, IgM, IgD or IgE type. Patients may exhibit bone pain, pathological fractures and radiological abnormalities in multiple myeloma, and these patients excrete Bence-Jones proteins, which is a dimer of kappa or lambda chains that are formed in a paraprotein. Basically, these are the light chains, that is kappa or lambda light chains. So serum zone electrophoresis and immune electrophoresis of concentrated urine is a reliable test for diagnosis of multiple myeloma patients. There is a test which detects presence of Bence-Jones proteins in the urine sample, which is called as a heat test. So here a slightly acidified urine when heated to 40 to 50 degrees centigrade will lead to precipitation of Bence-Jones proteins, and then this precipitated proteins will redissolve upon further heating urine to a boiling point, like going into 100 degrees centigrade, and then they will reappear when a sample is cooled to around 70 degrees centigrade. That means precipitation redissolving and then reappearing. So this type of phenomenon can be seen whenever Bence-Jones proteins are seen in the urine sample. That is what is referred as the heat test with Bence-Jones protein. A marked rise in serum globulin concentration is also observed in multiple myeloma patients. Coming to fibrinogen. The structure of fibrinogen is given here. So it has got two terminal globular domains, and also it has got an N-terminal cleaved, and also it has got a short domains which are central globular domain, and these central globular domains are removed by thrombin, which will be cleaved by thrombin, thereby fibrinogen is activated into fibrin. So fibrinogen, it is a precursor of fibrin. It is also referred as clotting factor number 1. Like globulins, it is precipitated with 1/5 saturation with ammonium sulfate, and it is asymmetrical and large molecule, and it is important for maintaining the viscosity of the blood. And all the three chains present in fibrinogen are synthesized in the liver. Now, the terminal ends of three chains have negative charges which contribute to the solubility of fibrinogen in the plasma, and that will prevent aggregation of fibrinogen due to electrostatic repulsion between the fibrinogen molecules. And the thrombin, it activates fibrinogen into fibrin monomer by removing two small peptides in the central domain, and several fibrin monomers, they aggregate to form a polymer, and that makes a soft gel kind of thrombus-like material. And factor 13 join a number of linear fibrin polymer to form a cross-linked fibrin lattice, and that's how the thrombus formation will go on. Now, changes in fibrinogen levels are seen in certain conditions, like decreased fibrinogen levels in the plasma is observed in severe liver diseases like acute hepatic necrosis, typhoid fever, antepartum hemorrhage, or quickly it will return to normal after delivery. Now, increased fibrinogen level is found in acute infections such as pneumonia, rheumatic fever, and tuberculosis. And also, since erythrocyte sedimentation rate, that is ESR, is affected by fibrinogen, so it is markedly increased in conditions whenever there is increase in ESR. Hence, measurement of ESR is used for assessing the severity and course of the disorders that are affecting fibrinogen levels. Coming to alpha-2 macroglobulin. Alpha-2 macroglobulin, it is a glycoprotein which comprises 8 to 10% of total plasma proteins in humans. The protein synthesized by variety of cells including monocytes, hepatocytes, and astrocytes. And alpha-2 macroglobulin has an internal cyclic thioester bond like complement C3 and C4. And also, alpha-2 macroglobulin, it is a pan-proteinase inhibitor, meaning it can inhibit most of the proteinases like elastase, collagenase, and all that. And alpha-2 macroglobulin, it transfers cytokines delivery to target tissues. And also, alpha-2 macroglobulin transfer 10% of plasma, zinc, and rest of the zinc in the plasma is transferred by albumin. So, these are all the different types of globulins that are found in our plasma, and all the functions and some of the characteristics and clinical applications of some of the important globulins that I have explained in this particular lecture. Thank you.